Well, thank you very much for this opportunity. So as introduced, I'm Aakash Desai from Mayo Clinic, and I'm going to be talking about therapeutic options in driver mutation positive metastatic non-small cell lung cancer, which is refractory to frontline small molecular inhibition. These are my disclosures. And so really, I'm going to break my talk into 4 different parts. Initially, we're going to talk about the metastatic non-small cell lung cancer and in terms of what kind of oncogene drivers are present, in this subset of metastatic non-small cell lung cancer. We'll talk about resistance mechanisms and then subsequently talk about the general and some specific strategies to overcome resistance in this area. So when we talk about stage 4 non-small cell lung cancer, the treatment landscape in 2022 is quite complex and is largely driven by 2 different factors. One, whether there is any presence of actionable mutation that is detected on the tumor. This is a list of ever-expanding mutations, thankfully. But currently, there are about 10 different mutations that we would want to test for, at least. Most of us send next-generation sequencing, which will cover most of these alterations. But for the patients where the tumors, we are not able to identify any actionable mutations, then immunotherapy forms an important backbone of treatment. And I think Dr. Kim will be discussing that in the later talk. My focus really is going to be in this subset, in this category of oncogenically driven metastatic non-small cell lung cancer. And when we talk about oncogene drivers, we've identified numerous different drivers for each, different tumor types within the metastatic non-small cell lung cancer. This plot here just kind of shows the prevalence and percentage of different oncogenic drivers. As you see, about 30% of the tumors are driven by KRAS, another 30% by EGFR, and then the rest, have a smattering of different fusions like ALK, ROS1, RET, and also ERBB2 mutations, some splicing mutations in MET pathway and others. And so within these 10 different actionable mutations that we know as of today, there are various approvals, and this kind of snippet just kind of tells us about the different drugs that are currently FDA approved and some of the data that has led to the FDA approval. I want to point out your attention to the ones that are mentioned with an asterisk, which are actually the NCCN preferred regimens in the current version of the NCCN guidelines. And I think it's important to realize that some of these approvals are actually in the second line for some of those newer upcoming oncogene drivers that have been recently targeted, like EGFR exon 20, KRAS G12C, and HER2. But a lot of the others, which we know quite along, especially for EGFR and ALK, which have been targeted, almost a decade now, most of these targeted mutation therapies are actually used in the first line, specifically osimertinib for EGFR. There's alectinib, brigatinib, and lorlatinib for ALK. There are a couple, for MET exon 14, NTRK, RET, as well as the ROS1 and BRAF V600E. When we talk about frontline therapies, this vignette here just demonstrates, different the duration of progression-free survival, meaning that when the time between the initiation of treatment to progression of the cancer for all these different targeted therapies across these different mutation spectrums that I just showed you. And I think what, kind of appears and stands out from this figure is that you would say that median progression-free survival is ranging from about 12 months to 36 months, 1 to 3 years. And that obviously depends on the molecular target. However, most patients will experience tumor progression with long-term follow-up. And most of this progression is mediated by resistance to the frontline therapies that we administer currently, be it osimertinib or alectinib, brigatinib, and subsequently others for other mutational subtypes. And so talking about resistant mechanisms, it is, I think, very important to understand when we see progression of the cancer after a frontline therapy, what is the mediated resistance mechanism? And there are, quite a variety of resistant mechanisms that have been identified till date. And this is just kind of some of the major classes or categories of resistant mechanisms that we see today. So it could be mutations in the target of the drug or the tyrosine kinase inhibitor that the patient is currently on. There could be switching of different bypass signaling pathways, so meaning other pathways from their mutationally driven tumor that are activated and subsequently lead to resistance and progression of the cancer, including oncogene amplification or oncogene rearrangements. The other mechanism could be the mutation in downstream effectors. So not just if we are targeting this particular tyrosine kinase domain, there could perhaps be mutations in the downstream pathway effectors, which could lead to progression of the cancer. And then another subtype of mechanism of resistance that we've identified is histologic transformation to a different histology from a non-small cell lung cancer, be it a small cell lung cancer or a non-squamous type of lung cancer being converted to a squamous a subtype. And so this histologic transformation is also another mechanism of resistance that has been identified.